So there's a reason for me having this in this particular interview, but when we spoke to Asha, she actually told us that her OBGYN was how she got into the conversation where breast cancer and early detection is concerned. So I'm happy to be joined by Dr. Earl Brathwaite, OBGYN, and this will be yours soon.
Oh, wow. Wow.
It will be, because like
Thank you for having me.
we were saying in the conversation that both of us shared the experience of our gynecologist being the person who said, hey, you have a lump, you should get this checked out. Mm-hmm. And that largely has to do with the fact that you guys are very in tune to the female body, hormones and all that good stuff, right?
Yes. We usually do routine breast exams, and we teach routine breast exams to most of our clients who come for their routine checkups.
It also is a place that we really have to be truly honest and very intimate with you guys. And so when we oftentimes have any sort of problems with our menses, anything female organs related, you're usually the first person we go to. And that might mean that we could probably look at how hormones and those sort of female features, if you will, impact the breast cancer experience, particularly the risk. Are there things that we could look for, indicators, or anything of the sort that we should know about?
Well, in terms of looking for risk factors, well, the main risk factor is being a little older, although we are still seeing a lot of younger persons develop breast cancer in recent times. And this is kind of a global event. So we want to really determine your, what we call genetic risk, to see if you fall into one of those genetic syndromes where you're at risk of developing breast cancer at an early age, and you warrant earlier intervention or screening or testing. And maybe not your routine mammogram. You might need an MRI, ultrasound, that kind of thing.
Okay, fair. Now, Dr. Oliver did talk to us about that early screening and those hormonal changes, but then how does the menstrual cycle in particular or hormonal changes affect breast cancer risk? Does it at all?
It doesn't really affect the risk. It would actually just change how the breast tissue may feel, and sometimes it can create a little bit of anxiety, especially in the premenstrual phase when the breast tissue is a bit more glandular, a bit more dense, and sometimes can feel a bit more irregular and sometimes even tender. So we do get a lot of ladies coming in around that time who says, Doc, I'm feeling something weird. But we try to teach them to do the breast examination at home at different points in their cycle so that they can feel what their normal changes are in that cyclical pattern. The main changes that might impact the breast cancer risk is actually more prolonged or chronic exposure to unopposed estrogen. So for persons who may have hormonal imbalances like the polycystic ovary syndrome and that kind of thing, they may be at a heightened risk for breast cancer in their lifetime. Also, ladies who start on their contraceptive pill journey for contraception, usually within the first couple of years of use, there's a little, very nominal spike in the increased risk. Now, some studies have shown that, when you look at the whole risk over your lifetime, it doesn't really go up too much, especially after you've discontinued the pill. But in those first couple of years, some studies report a little bit of spike in risk.
What I'm hearing is getting to know yourself is really important.
Very much.
But one of the things that we've learned recently is not just that breast cancer can occur in females, but also in men, right?
Yes.
So similarly for men, there will be things that they could look for, probably not hormones or menstrual cycles. But what should they be paying attention to then?
Well, it's actually pretty much the same thing in terms of now the male diagnosis tends to be a bit more, if there's something wrong with our chest, we tend to report it a bit sooner. And this is because we wouldn't have much breast tissue, so it would be easier to notice that there's something irregular on your nipple, on asymmetry in your chest wall, that kind of thing. So basically a lump, basically to examine. Usually if there's something wrong in men, we tend to ignore it. So
getting to the doctor is important. Another important thing that we learned though was that a lump doesn't always mean cancer.
It doesn't.
So that at-home check, that first few, getting to know yourself step really is going to save you a lot of panic and a lot of worry then.
Yes, it is. It will.
For sure. I know it does save me. But some of the things that would also save you, should you become diagnosed, would be the support that you can get from your family and even knowing the history of your family.
Yeah.
So let's say you may not find something, but you're curious. You're concerned and you want to have that conversation with your specialist. How do you start that conversation? What should we be aware of family-wise?
Well, it's pretty easy to get a family history, basically if you know someone in your family who has that breast cancer, has had breast cancer. But the main risk comes from that first degree relative, right, who has been diagnosed with breast cancer before menopause, right? So when they've been diagnosed before menopause, that carries now the heightened risk. And that should prompt the individual now to do more genetic testing to see if they carry a gene where there's a high risk of breast cancer in their lifetime.
Now, lucky for us, we've also learned that it's not necessarily just from the hereditary part of things. Many are cancer patients or incidence of cancer are sporadic. So we still getting tested,
yes, we still,
early detection altogether. But at least that can guide the conversation. If it's in your history, it's something you want to disclose. Now, one of the things that I wanted to ask about personally was pregnancy and cancer. Just because you gave me some really interesting information that pregnancy kind of helps.
Yes. So pregnancy and breastfeeding actually seem to have a protective effect of your lifetime risk of developing breast cancer.
How so?
Now, it has to do with a long history of being exposed to unopposed estrogen, right? So we see a heightened risk in persons who've never been pregnant, persons who start they're having their periods very early and they go into menopause very late. So that long history of, no interruption with breastfeeding, with pregnancy, they see a heightened risk. And they think it's related to the estrogen exposure over the number of cycles you have in your lifetime.
You're talking and my brain is doing the math, because if you see culturally, we have a lot more younger females who are actively choosing not to have children.
Right.
It might correlate with why we're seeing younger persons having cancer diagnoses?
Not necessarily. Not necessarily, no. So we're talking about lifetime risk. And again, the majority of cancers are going to happen after 40, after 50, right? So the younger people that we're seeing with this high incidence and prevalence of breast cancer, most of them are genetic syndrome, genetic carriers.
Outliers, essentially.
Yeah, outliers, yeah.
Because the 40s or the persons over the age of 40 are in the majority still.
Yeah.
Okay. Kind of relieving, I guess. But I think the most relieving thing is that we have ways that we can check ourselves. There are resources that we could use. But let's talk a little bit about the actual self-exam, which is where our friend the grapefruit comes into play. Because when we talked about it, yes, you're going to demonstrate to us, but it also posed the question of persons with that newer lifestyle as well. Implants.
Yes.
A lot of persons, well, women, younger age women, are getting implants now. And I wonder if that poses a threat or thoughts in any way, the ability to detect things?
It can in a way. It depends on the type of implant they have.
Okay.
Now, when implants first came about, a lot of people were using the silicone, which was more of an opaque implant. And they were having very tense breast structures with these implants. They were kind of overfilling the breast cavity. Now we're seeing more saline implants and people going for more of a natural look.
Right.
So that the breast tissue will still be able to be examined properly, be able to be compressed properly. And actually the saline implant is actually better at visualizing the breast tissue.
Okay.
Because a lot of people, when they do their implant, there is a shift where the breast tissue now is spread over the implant, right? Now we have some people doing implants where they put the implant underneath the muscle. So it doesn't really interfere with the breast tissue too much. So it's up and down. So some can make it difficult to assess.
But not to the point of risking your breast health.
More recently, not.
All right. So I feel like we should probably get a demonstration at this point, because you would want to be doing this at home in the privacy of your home yourself. Yes?
Yeah.
So what do we do?
So how I teach breast examination is basically to make sure that we evaluate all of the breast tissue, inclusive of breast tissue that sometimes may go up into the armpit. Because as I said before, the upper outer quadrant of your chest wall, that has significant amount of breast tissue, and in some ladies, it can actually go into the armpit. But the armpit is also very key to evaluate because the lymph nodes in the armpit are where breast cancer may spread to as the first mode of spread. So, grapefruit time?
Okay.
All right. So, well, the first thing is to look for symmetry. So you have to know that usually the breasts aren't symmetrical. So you have to know which one is bigger, which one is not bigger from the get.
Okay.
So you have to basically, you have them in front of the mirror, and they put their two hands on the head or just above, and they're looking dead on, and they're seeing, okay, are the nipples in the right position? Is one diverting more than the other, right? And again, they have to know what the norm is, right? And see which breast is bigger than the other. So let's get on to, after inspection comes palpation. So palpation, we usually want the hand, one is the exam hand. This hand basically engages the pectoral muscle, the chest wall muscle. So that provides a platform for you to press the breast tissue against, so you can basically knead out the tissue against this chest wall to see if there's just glandular tissue, normal tissue, or a discerning lump, right? So usually you feel with the palm of the tip of the fingers, and you go around in each quadrant. You can divide the breast into quadrants, and you want to attack each quadrant, right? Now, after you attack each quadrant, you want to take the two fingers like this, almost like pinching, and you go underneath the nipple, the areola of the nipple, right? And you go around in circles all the way around, basically trying to squeeze as much tissue between the two fingers and to discern if it's just glandular tissue or if there's a discrete lump. Then you want to express from the nipple, because nipple discharge is also a sign of breast cancer, can be, right? So you want to squeeze the nipple to see if there's any discharge from the nipple. So after we do that, now we kind of pay more attention to the upper outer quadrant, and we follow it into the armpit. So you want to hook underneath the pec muscle and come from top to bottom. Now, with the chest wall muscle engaged, you may not get deep into the armpit. Right. So after you go all the way up, you bring your hand down, and then you come down to reach back to the breast, right? Then you go back up, you feel in between the two muscles, the back muscle and the chest wall muscle. You start from up, and then you bring it down, and then you knead and come again, and you go back up, in, and then you knead and come again. And repeat on the next side.
How often should we do this?
Usually once a month, and you can try at different points in your cycle again to see the different changes based on the hormone levels.
Okay. So I think we've got information we could use. You've definitely reassured us in what we can do and to continue to strengthen those relationships with our doctors. So thank you very much, Dr. Brathwaithe.
Most welcome. Thank you for having me.
Although you barely used the grapefruit.
Oh, sorry.